Interesting thing, my family came from Cuba. I was born there. My parents came in the mid-'60s. And I have this feeling, my father's parents were also immigrants. They went from Jamaica to Cuba. And something about that Jamaican side in particular, they're awfully ornery. My dad could be kind of ornery. And I think in general, immigrants are that way because they kind of say, you know what, I am going to leave what is safe. I am going to leave what I know because I think I can do better. They go with this hope, and they sometimes take steps backwards. You might be a doctor, but you may not have the language skills, so you drive a cab until you can get yourself back into the profession of healthcare. And it seems that when it comes to innovation and disruption, when I talk to folks in healthcare, they have that same kind of orneriness. We live in the best of times and worst of times in terms of what we can deliver, and yet we all feel like we really can do better, and we need to do better. You are two leaders, Larry Merlo, the president and CEO of CVS Health, who is embarking on a real new and different path for your company, and Bernard Tyson, the chairman and CEO of Kaiser Health, is often held up as really what a lot of health systems want to achieve in terms of population health and in terms of integrated care. I'd love for each of you to talk about what you're ornery about. What is it that you feel
Well, yeah, Larry.
we want to do better in the way that you are approaching disruption and innovation?
Well, Bertha, you answered a very important question, because when my colleagues turn around and say, Larry, why are you so ornery today? I'm going to say it's because we're in healthcare. Bertha, I think as we look at our healthcare system today, obviously it has challenges. Many people say the system's broken. We would sit here and say, our healthcare system was created for episodic care in a fee-for-service environment, not one that is created to support and provide for the individual healthcare needs of consumers. And healthcare has grown to almost $3.6 trillion. It's 18% of GDP. It's continuing to grow. We know more than half of all Americans suffer from one or more chronic diseases, and the dollars that we're spending on that are not helping those individuals to achieve their best health. And I can go on. And you think about the size of this industry and the fact that everybody is frustrated and dissatisfied with the results that we're getting. So I think that's a pretty good reason to be ornery in terms of we've got to do something different. The status quo is not sustainable as we think about the health of individuals, the health of communities, and the health of our country.
Bernard, you're doing integrated care. You're kind of doing it right. Why are you still ornery? I mean, I don't want to assume that you are, but I think it's part of the condition of healthcare.
No, I'm feeling great. I'm with the trees. I'm walking on thin air. I get to dream up here. And
Right, everyone remember to drink some water.
It's all good. Yeah, please, everyone, drink water. I think, and picking up on what Larry is saying, I think that we have to come to the reality that in the 21st century, a sick care model is not the right answer. That we have to rethink the narrative, and it's about health and well-being, and to use my term inside of Kaiser Permanente, how do we maximize the healthy life years of individuals? I think that's the first part, which suggests that we move away from a fix-me system to a whole health system that is not bound by the lane that we're in now, called healthcare. It looks at bringing all aspects of health as an ecosystem.
So it's not bound by the four walls or the many parts of a health system campus.
Yeah. For our 12.5 million members, for the ones who are living in communities in which they can't get fresh foods, we can benefit their health more with figuring out how to solve to that problem and then helping them understand how to cook, how to exercise, building a more safe environment for them to play and to live and to, in essence, reduce the stress level and to exist in a very competitive environment. We all live now in the 21st century, a whole different set of circumstances that we all face, from trying to figure out how to get through the day to being wired 24/7 to trying to figure out how to deal with multiple demands. We live an exciting life. It does something to the body, and the body needs to be in great shape to take it on. And so, how do we design a health system that focuses on prevention as the best medicine, which speaks to self-care, and then early detection, early diagnosis, early treatment? How do we deal with a system of coordination of care and services that deals with what you just described, chronic care, and doing it in a way that is not episodic, right? And so we have models. Our physicians at Kaiser Permanente thinks that if one of our members comes in from a diabetic attack, that's a failure of our system to figure, because we haven't figured it all out, to keep that member as healthy as possible with diabetes, outliving their life. And so that's, I think, the both exciting and daunting challenge that we have in front of us.
One of the things that I think makes our system different, I often say to people, no one in their right mind would ever design a system like the U.S. health system in the way it has evolved, because it just is not efficient, and in a sense, it works in opposition to doing what you're trying to do at Kaiser and what you're trying to do with the merger with Aetna, and what you're hoping to do in terms of this new model of a community-based, more affordable care. Our health-based system here is really based on opposition. Payers and providers, PBMs and drug makers. Everyone's sort of fighting to sort of say, I'm the one that's bringing the value, you're the one that's causing the problem. How do we solve that? Do we solve that just by, in a sense, we get married and we all just become part of one family and vertically integrate so we don't have to spar as much?
Well, Bertha, listen, I admire what Bernard has done at Kaiser, because I think he has created the framework for a solution in that, he is centering healthcare around, the patient. And I think the challenge that we have today is you look at healthcare, it's a series of transactions, and who's connecting the dots across those transactions versus the opportunity that we have to provide care management, to patients, consumers, individuals. Those words are all starting to get blurred now, and I think that's the direction that we need to go. We need to take healthcare to where the people are, okay, to the communities in which they live and work, and it's the opposite today.
So in our system, we all think that it happens through competition. If you succeed in setting up what is sort of essentially a different kind of model of almost primary care in the retail setting, in most every neighborhood where there's a CVS, and there are a lot of neighborhoods where there are CVSs, they're coming to mind, thank you very much. Does that then threaten the hospital? Does that then threaten the physician's office? The AMA just sort of came out in opposition to your merger, feeling that it threatens them in a bit.
No, Bertha.
Let me put two mics on that then.
Let me go back to, Bernard, talked about, that patient with diabetes, okay? And, if we play that out here for a minute, because I'm sure everybody here knows someone, okay?
Or hypertension.
Well, that patient is probably going to the physician, 3-4 times a year. They leave the doc's office with a care plan, and if they're, patient with diabetes, it's medication, it's diet, exercise, nutrition, And here's where the system breaks down, because no one knows what's happening in terms of, is that patient following that care plan in between visits. And the fact that we're in communities all across the country, we believe that we can fill that void, and we can be a complement to the work of the physician, the work of that patient's medical care team, to keep them adherent to that care plan, because the studies are out there, and there are folks here in the audience that have written them that have quantified the fact that there are significant numbers of patients with chronic disease that are not following that care plan. It's costing our healthcare system billions of dollars every year in avoidable and unnecessary costs, but at the same time, we're not helping those individuals achieve their best health. So I don't see this community-based model as a replacement for hospitals or physicians. I see it as a complement to the work that they do, because of the voids that we see going on all around us in healthcare today.
Yeah, I would second that. I think that one of the things that we have to be careful about, first of all, in my narrative of recrafting how we think about health and healthcare, in no way do I want to diminish the great work that's been going on in the healthcare industry. As I'm talking to you right now, I promise you with my own statistics, my doctors and nurses, most wonderful people, they're operating on a patient right now, and they got the chest open, and they're going to do this great heart surgery, and that patient is going to be up in the next couple of hours walking around. And in our system, because of all the wraparound services, they'll probably be going home in the next couple of days, starting a brand new life, right? So to that patient, they're going, this is a great healthcare system. To the innocent one who may pass out in the streets, that now in the healthcare industry, we could diagnose you immediately and figure out what to do about you. We're living in a day and age where we have figured out how to cure a certain illness. So great progress. But that's a very expensive system, and it's focused on sick care and fix-me. And what we're describing here is a whole new ecosystem of health, where it comes together as a whole system, as opposed to is siloed now in each part of the industry. And we have a real opportunity to innovate and redesign the whole healthcare landscape.
And yet, that's an expensive proposition too. So if you're not relying just on the gazillion-dollar MRI machine or latest technology to solve problems, it really comes down to people. You take that data, and now you have to make it actionable. And we are in an era in this country where the hunt for talent is really very competitive. So as you build out your community-based retail health system, as you build out and do more social determinants of health programs, you need people to go out there and interact. Where are you going to find the talent?
Well, Bertha, I don't think there's a company out there that doesn't have as one of their key priorities, how do you attract, inspire, and retain, that top talent? And, listen, we all have a number of programs, that, whether it's, training programs. I think one of the dynamics that, that we're beginning to see, especially, in this millennial generation is, we think about what we were focused on when we were out looking for that, first job or perhaps that second job. And, in today, I see many, many more people that want to understand the purpose of the company, the purpose of the organization, what's the mission. And they want to be inspired by that, and they want to make sure that their work, has a contributing factor to whatever that happens to be. And I think, for reasons that we're talking about, we can deliver, on that part of the inspiration. And I think, in our particular case, we have a set of diverse assets where, we can create unique development programs, to help people grow, in their roles and achieve their professional aspirations. But at the same time, I do think that innovation, around, attracting talent is going to, need to be different. We've, piloted a program we started a few years ago where, we actually have created an apprenticeship program for pharmacy technicians. It's now across 12 states. We have about 5,000 of our colleagues enrolled in that program. It's been absolutely a home run. And I think we need to think, more like that in terms of all the other opportunities that, can apply in a similar fashion. We would have never thought about that, 4 or 5 years ago.
Yeah, I agree. We have, training programs and things that we invest in around our people. We're opening up a medical school in 2020 in Pasadena. And we're on a mission now to really, through our Permanente medical groups, teach future physicians about team-based care, stress management, all the things that we practice inside of Kaiser Permanente. So we want to make a bigger contribution to medical education. We also have a challenge, and it's an opportunity. We have 220,000 employees, and some of our issues are around, as we introduce more technology into healthcare, how do we bring the workforce along? And how do we make sure, at least in Kaiser Permanente, everyone is clear that our technology strategy is not a replacement strategy of the human touch, it's an extension of that. It helps to enable that. But how do we continue to build the skill sets in our organization and to make sure that people obviously feel empowered towards the destiny that we're creating together, as opposed to a victim of something that's being dictated to them?
Where do you feel we are in the game? We were talking earlier how some of this disruption and innovation isn't about that big bang, isn't about the big home run, but hitting those singles and ground balls, just to keep the metaphor in baseball. What inning do you feel you're in?
The third inning, the first quarter, the third tee.
I'll tell you what, you're ahead of where we are, so that makes us the bottom of the first, I guess. So,
I think.
So, tell me what it looks like when you get at least, say, to the 7th inning stretch.
That the whole health system is now community-based, and technology connects everything. And
so the whole health system being Kaiser Permanente, or Kaiser Permanente being able to talk with CVS, CVS's health system, or talk with Geisinger, or talk with Mount Sinai.
Oh yeah, that's a big piece of it. The whole interoperability is critically important. But I'm talking about.
I won't tell you, my mom was in the hospital last fall, and the resident just said to me, listen, even within Mount Sinai, the easiest way to get her records is to fax them. Within Mount Sinai, even though they're all on the same record. So, it's frustrating for people who really want to do a good job, want to push the way forward, and it just feels like they have to work so hard to do it.
Yeah, well, the walk from paper-based to, electronic health records and et cetera is a challenge. But I would also tell you, though, once that platform is built, there are so many things you can do differently now. We use the metaphor inside of Kaiser Permanente because it's our reality now, is that care can be anywhere. So the idea that we have historically in the industry designed a health system, quite frankly, with the hospital being the centerpiece, and everybody had to come in, and then you have medical office buildings, et cetera. But what we did was we trained our patients generally that you had to come to us for everything. Well, now with technology and everything, we're demonstrating that no, you don't have to come in for everything. I'm connected. I can email what you need. I can
And you do more than
secure
half
messaging.
of your interactions digitally.
Yeah.
Because frankly, a lot of us are too busy to have to even call. I've become like the kids. Text me.
Yeah,
I'm
and
not
it's a
picking
way
up the
to
phone
empower the person, the consumer. It's a different kind of relationship, but it's based on a relationship with your provider. Now, as I say that, there's a lot of re-engineering that has to go on behind the scenes, because a day in the life of a physician, for example, is very different today than it was 25 or 30 years ago. And so how do we reorganize and rethink, for example, so what does productivity means now? How do we think about access now?
And combat burnout as we
and how do we deal with
more
burnout?
and more
Exactly.
responsibilities. I mean, my mom's, geriatrician, God bless her. She's not in direct primary care. She is not in a concierge practice, but she spends time with her patients, and she will text you and call you back.
Yeah.
Not everybody has time or really finds a way to do that.
Bertha, I see this dynamic. You're hearing people, begin to talk about, consumerism in healthcare, and a couple of years ago we started talking about the retailization of healthcare. Why did we use that term? Each and every one of us, here, we're consumers of something, and whatever that happens to be at the moment, you're making your own value proposition about where you choose to go. It may be based on convenience, price, service. You're defining your value proposition.
At that particular point in time,
At
because
that,
it may change.
you're right, okay? But the question that we have to ask ourselves is, do we have that in healthcare today? Because you see benefit designs, plan designs, pushing more decision-making and accountability to that, let's call them consumer of healthcare, but yet the tools to support that thought process, are they there? And I think, all too often they're not.
Sometimes they are, and there's so many of them you don't know how to navigate them. And again, they're all there. Your large employer has put them all together, but they don't necessarily coordinate with one another. They have their little lane that they're very good at, but don't always coordinate.
But in part, that's why I'm saying we're in the third, now fourth inning.
All right, I'm now in the top of the second.
Because we start with an integrated model,
Right.
and we start with the end-to-end responsibility, right? And so if you look at the industry that is still basically on a fee-for-service chassis, I would argue that incents the wrong behavior sometimes. Not bad people, it's just the incentives are aligned where I have to produce a certain amount of volume to get a certain amount of payment. And our model says, I'm going to pay you to take full responsibility working with individuals and population to produce these outcomes and these results. I think that there are a lot of challenges now in how we continue to transform that to become even more relevant to someone living in the 21st century. And so for me, it is a combination of how do we continue to perfect medical excellence, but also how do we look at all the wraparound services that we should be engaged in, involved in on behalf of our member and the communities in which we exist. So a medical record of the future, or medical information of the future, will not just have my blood pressure and all those wonderful things. It would talk about what my social network looks like. It will talk about what my eating possibilities are or challenges are. It will talk about my stress levels at a different level. And quite frankly, I will have much more wrapped around me with sensors that gives me a chance to better understand my body and what I can do to take more responsibility for my health. And by the way, make it all cool.
Making it all cool. And speaking of cool, I want to open it up in the last few minutes we have to the audience. I'm sure folks have some great questions they want to ask. Gentleman here in the shirt, I think we have a microphone for you.
Stephen Summer from Denver, Colorado. Larry, I'd like to ask you whether you have any plans now that you've bought an insurance company to move away from the fee-for-service model and move more to what Kaiser has, since you identified some of the problems with fee-for-service medicine. You're combining drug company with CVS with an insurance company. Does that give you the opportunity to go in a different direction?
I think that this combination absolutely gives us the opportunities for new plan designs, that incentivize the right behavior in terms of some of the things that Bernard was just alluding to, and that's something that we're anxious to get started to work on.
back in the corner. Sorry to make you run.
Hi, my name is Amy Lynn from Washington, D.C. I work in global health, and it's a really interesting discussion. I wanted to pick up on that last comment of let's make it cool. I think a lot of what we struggle with in global health is how do we encourage our target communities to pick up on the interventions or the practices that we think are important? How do you think about using marketing practices or retail strategies or others to cut through the noise of the everyday and empower the consumers with the information they need and only that information and make it attractive for them to act on it?
Yeah, I mean, I think that's a big part of our challenge in the healthcare industry as we are continuing to transform and to figure out how to reach populations and individuals in very different ways. We're doing, for example, we're committed to destigmatizing mental illnesses in this country. And we have arrangement with unbelievable people who have been willing to work with us, from sports stars, Steph Curry, who's been doing some media work with us. We kicked off our campaign with Kendrick Lamar, who brought a wonderful song about I Love Myself. And we have figured out how to put that into our first campaign to target children to say, if you are having something that's going on, find your words. I think we have to look at modern tools and techniques that gets the attention of very busy people who are listening to a lot of noise every single day. And we have to step out of our internal stats that we love to talk about. No one understands HEDIS except for us, right? And so we got to figure out how to make all of that relevant and cool to the 21st century. And I think it's very exciting, by the way.
We've got time for one more, the woman in the coral.
So thank you. My name is Stella. I'm from Kenya. I mean, it's interesting to listen to this discussion about how you're moving away from out-of-pocket payment model of financing healthcare systems. Yet, in where I come from, like in Kenya, for example, is that we are trying to kill the community health model system and moving towards more of, in terms of financing, we're either having insurance-based, we're either also having the out-of-pocket, and this is just actually being driven by the market forces and being driven by privatization of healthcare. How then do we, as we sit here discussing about global solution, and it actually touches across the globe, and how do we carry some of these lessons and ensure that even as you're coming in, as investors are coming in within developing countries, that the same models are actually being adopted instead of pushing towards market-driven forces of healthcare systems?
That is a panel in itself.
Yeah, that's a great question. I'll start.
I'm thinking about my answer to that.
You know, I think that we will not really see, and I would put Kaiser Permanente in there as well, the total transformation of healthcare until we've also redesigned the economics of healthcare. And the idea that we can stand up and say truthfully that we have the most efficient, effective healthcare system on earth, and we think the next set of solutions is how to add to that, I think we would be kidding ourselves, both as a health system and as a country. I think that part of our work ultimately is in the empowerment of the people who are actually paying us for the things that we do, but done in a way that the incentives are aligned for the right behaviors and outcomes that we need to do. The fact that we haven't even figured out how to really tell you how much we're charging as an industry for what you are actually paying for is a great example of how far behind we are as an industry, right? And there's no such thing as, and there's no such thing as we cannot do it. In fact, we're going to prove it one day at Kaiser Permanente that really puts it in the same terms as a true consumer going in for anything else. That's unstacking a lot of things in the industry to better understand that. I think the second thing is there's a big difference between access to coverage and affordability of access to coverage and access to care and the affordability to access of care, right? And we deal in this country where people are trying hard, paying money to afford access to coverage. But then when they need to interact with the care system, they discover there's a big gap in the affordability of how do I now get the care. Until we solve those two things, we are a long ways from transforming healthcare in this great country.
And you know, Bernard, you said that very well, by the way, but you know,
Bring it home.
well, no, I'm
He's
going
waving you in.
I'm going to give you an example, okay? Because in our shop, we just had a discussion about what is transparency and how do we make transparency actionable. And I'll give you an example of something that we're in the process of rolling out, because there's been so much rhetoric and discussion about drug pricing. But yet, think about that physician when he or she is writing that prescription. That doc has no idea the out-of-pocket cost of that medication for their patient. So we're in the process of embedding, that patient's plan design, in the patient's EHR. So when the physician goes and, puts that prescription in, assuming they're prescribing it electronically, and today about 80% of all scripts, are prescribed electronically, he or she will be able to see the patient's out-of-pocket costs and up to 5 alternatives and the cost associated with each. One of the things that we're seeing is physicians are switching to a lower cost alternative 30% of the time with an average savings to the patient of $70. Yeah. And I think, Bernard, that's a great example of what you're talking about.
Yeah, absolutely.
We could go on here for hours. We didn't even get to my pet peeve, and I won't give you my rant on billing. It's not just, you can't tell me how much it costs. Why does it take 7 different times to bill afterwards? But
Next year.
I will spare you. I will spare you. That is my personal rant, and one of the things I think really bogs everything down. Thank you so much for your thoughts, and I think you've given us a lot.
Thank you.